All right, we'll get started here. Okay, so good afternoon and thank you for joining us today. We are excited to be hosting a webinar on this content and we'll be recording it for everyone that was unable to make it to the live event. WYPCA wanted to identify an avenue that we could provide training or TA that could assist health centers in grant writing. And we are so pleased to have connected with Health Landscape, who will impart techniques to make UDS work for you as a source to convey the needs of your community in reporting, applications, and planning. Today we are joined by Jessica McCann, User Engagement Specialist, and Jennifer Rankin, Senior Manager for Research and Product Services of Health Landscape. Jessica directs user support, development of support materials, and new user training. She has previously served as analytic geographer with the Robert Graham Center. And then Jennifer Rankin also served at the Robert Graham Center as the Geospatial Informatics Senior Analyst. She directs all geospatial projects for Health Landscape, most notably the UDS Mapper. Both of these incredibly smart ladies share a passion for health equity and access to care. Thank you both for being here today.
Thank you, Hannah. We want to thank y'all for hosting us today, and thank you to everyone who's joined us today for the webinar, Finding Areas of Interest for Health Center Planning. As Hannah mentioned, my name is Jennifer Rankin, and Jessica McCann will do the second portion of our webinar today. Just a quick word, we are both working from home, so I apologize in advance for any background noises, dogs, children, husbands, that you may hear. Just to put it out there, the UDS Mapper and this presentation are both supported by HRSA under this contract number. And today we're going to talk about using the UDS Mapper, introduce you to the concept of using it as a tool for community health needs assessment. We're going to be starting by talking about community health needs assessments in general. Then we're going to discuss how the UDS Mapper can be a useful tool for these types of projects. And then we're going to do a specific use case of an example in Casper, Wyoming. And then we're going to show you to make sure you know all the user support tools that are available throughout the UDS Mapper tool so that you can then start to do these types of projects on your own. Before I go too far in, and this may seem kind of ridiculous because of the number of people that have signed on so far, but I'm going to launch a poll question. In the 10 years that we've done webinars, we've not done this, but I'm just curious, for those who are attending, how familiar are you with the UDS Mapper? If you could go ahead and answer the question, let us know. I'll close the poll shortly. I think, there we go. So it looks like we are a fairly new group to the UDS Mapper. So we'll make sure that we cover some of the stuff more in detail that you may not be as familiar with. So let's talk about what the UDS Mapper is. It was created almost 10 years ago, so our 10th anniversary will be July 1st. It was created so that the Health Resources and Services Administration, the Bureau of Primary Health Care, and health center organizations had access to tools and data that could assist them with evaluating the geographic reach, especially the penetration and growth of the health center program, and then examining the program's relationship to other federally linked health resources. As Hannah mentioned, Jessica and I both work for Health Landscape. Health Landscape is a division of the American Academy of Family Physicians, and AAFP has had this contract for the full length of the UDS Mapper life. We collaborated with another part of the AAFP, the Robert Graham Center, that you heard Jessica and I both used to work with, but also worked with HRSA and John Snow Inc., so the contractor that works on your UDS data, to help develop the UDS Mapper. The tool itself is a free online tool that uses data primarily from the uniform data system that each of the health centers provides each year. Each year, you submit the data, both awardees and lookalikes submit data on your patient characteristics, demographics, quality, services, and costs to the UDS. We will discuss this a little bit more in more detail later, but it's those health-centered data that are the foundation of the mapper. Prior to 2010, when we launched the UDS Mapper, the data were not available to the public at this local level. It was part of this release of public data that HRSA and the Bureau of Primary Healthcare decided to create the UDS Mapper project. And we've built that as part of our overall health landscape mapping platform. The UDS Mapper was originally built based on formulas and reporting methods developed by the Bureau of Primary Healthcare to look at service area overlap. And over the years, as you'll see from this particular webinar, over the years, new use cases have been identified. So we've added additional data and we've added additional functionality. The UDS Mapper is, is open to the public at no cost. Anyone can use it. So we have quite a variety of people who are registered users of the UDS Mapper. We have had some people create a single account for one organization, but we want to make sure everyone knows that you can have your own unique login to access the UDS Mapper. And all you have to do is fill out this form. As soon as you filled out this form, you can start using the UDS Mapper. So we'll try this again. We're going to go to poll number 2. I'm just curious, of those who have joined, what is your current job function? Great. Administrative staff and I'm assuming PCA staff as the second answer. The UDS Mapper is used by a wide variety of people at health centers and at the PCAs that support them, as well as the primary care offices and the state office, State Department of Health. Those are in different places in different states. But the whole wide variety of organizations that support health centers, everyone seems to know about the UDS Mapper and is using it. Community health needs assessments specifically result from a process of identifying and prioritizing community health needs in order to take appropriate actions to improve a community's health. While the CHNA involves collecting and analyzing data on a community, direct input from the community is essential to confirm or even override the data analysis. So, for example, what that means, I went to graduate school in Houston, and when I was working on my dissertation, I worked for an organization that did community health needs assessments for neighborhoods with an aim to then link the people in the neighborhoods, link the leaders of the neighborhoods to appropriate funding organizations to help address their health needs. In one particular neighborhood, that all the data that I worked on, so I found all the data for this particular area, it pointed to that their health problems that we should most likely focus on addressed improving their health. So it was liver disease and smoking. Those were the two things that all the data point to, that if we address those things, we would make the most impact on health in this area. But we then went in and met with the community, and they let us know that their most pressing need was that Houston, which is below sea level, every time it rained, there was flooding that brought sewage into their apartment courtyards and just flooded their apartments, the lower level apartments, with sewage. So that local knowledge and local experience overrode that data analysis, and that should happen almost every time. The assessments that we do when we do community health needs assessments are used to set community health priorities, plans, and strategies. And with the CHNA we completed for the community in Houston, instead of going to funders that work on smoking cessation or liver disease, we went to those that work on issues related to the built environment and housing. As you probably know, there's a lot of literature on community health needs assessments, and here we're paraphrasing Sarah Rosenbaum's 7 principles to consider for the implementation of a CHNA process. I can speak to these principles using the example that I just mentioned. We worked to identify all health-related organizations that were in or serving the community so that the overall plan would be accepted and endorsed in the community. This collaboration and shared ownership from the beginning and throughout the life of the project is the foundation for its success. We did not rely only on the organizations that serve the community. We made sure that people in the community also had a voice. Community engagement means community participation, which leads to improvement in health status or health outcomes. To identify, to define the community for this work in Houston, we started with the service area of my organization, which encompassed the Houston region, including 5 or more counties. But the needs assessments ended up being for much smaller areas, traditional neighborhoods, or in this example, a series of garden-style apartment complexes where Vietnamese refugees had settled. You must be able to get health data for this area, so whatever area you're focusing on, you have to be able to get health data for that area, because to demonstrate measurable results, you have to be able to measure something, and health data are usually presented at some geographic level, like census tracts or zip codes or counties. The larger the area, the less likely you will be able to find the same or similar issues in all parts of the community. Therefore, it will be harder to get community buy-in and participation. And remember, we mentioned to get your stakeholders involved and be collaborative. This meant organizations had to be transparent, and in this case, share data with the collaborative partners that they had never shared their data with before. Once you have identified the issues to be addressed, try to find a program that has been successfully implemented elsewhere to replicate it in your area, or develop one that is based on evidence-based interventions. Remember what we need to do to demonstrate measurable results, and that it is not possible without an evaluation plan. And we want to find data that are for the geography in question, that are as up-to-date as possible and from reputable sources. If you're using quality data like these, they should be available in the future for further measurement and evaluation. So how can the UDS Mapper help you with your CHNA? Let's go through a few of the principles we just mentioned. Regarding the use of the highest quality data, the Mapper has health center specific data, and it's the only place you're going to find those health center specific data, including health center program data, and then demographic data and population health data. All of the data that we include in the UDS Mapper are the most recent available, come from reputable sources, and are available for the same geography that we use in the UDS Mapper. The UDS Mapper also allows you to upload data for any point locations as long as they aren't patient addresses. And regarding the definition of community, you can view community in the Mapper using your actual service area, and that means where your patients live, or you can view your funded service area, which is could be a much different area than what you're currently serving, especially with the impact of the COVID pandemic. Or like I said, you can start with a much larger area, maybe even the whole state, and then whittle down to an area that makes sense to you and the analysis that you're doing. Whatever you choose, you can look for growth opportunities and identify areas where your service area may overlap with other health centers. Regarding the analysis of community data, you can use the Mapper for visual and data analysis, including thematic mapping, threshold mapping, and looking at data from disparate sources at the same time to really identify your areas of need. So focusing on the data first, the data in the UDS Mapper come from several sources. The Uniform Data System, or UDS, provides the information we have regarding patients. The majority of these data are aggregated so that we can study the health center program as a whole to understand what areas are already served by any health center organization. We also have a special tool that lets you look at individual health center actual service area. So rather than asking where did the health center program as a whole serve the community, and in this case, right now, we're looking at the 2018 data. You can ask, where did my health center patients come from during that same year? There are also other ways to find individual health center data throughout the UDS Mapper, but the most detailed information about health center organizations can be found in what we call the information card deck, which we will show later. The UDS Mapper wouldn't do us much good if we couldn't compare all of that patient data to what's going on in the communities. Therefore, we combine patient information with population data. The bulk of these come from the American Community Survey, including total population, population by poverty level, population by age, race, ethnicity, and more, as you can see on the screen. We also pull population health data from other sources, including the HRSA Area Health Resource File, the CDC Behavioral Risk Factor Surveillance System, for example. The data do not automatically come to us at the correct geography that we're using in the UDS Mapper, so we do some estimation techniques to be able to provide these data at the correct geography. The UDS Mapper does regular webinars, and I believe our advanced webinar next month will be focusing on data. So if you want to join us to get a more in-depth information about all of the data in the UDS Mapper, I recommend you join us for that webinar in July. So I told you that we're using the same geography throughout the UDS Mapper, and that turns out to be zip codes. And that's because health centers are reporting their patients by zip code in the Uniform Data System. But unfortunately, zip codes are an unreliable geography. They don't represent an area, but rather a delivery route. So anytime you see a map that represents a zip code as a shape, that is not an official US Postal Service product, and therefore may not match other maps that represent zip codes as an area or shape. The zip codes themselves can change anytime the US Postal Service needs them to change, so they're unstable. So for example, when I was doing my research in Houston in graduate school, there were several suburbs that were very booming areas, and in the middle of doing some of my research, a zip code split in half. There were so many people moving into that area that they needed to split that zip code into 2 different zip codes. So they change just whenever the Postal Service needs them to. The ZICTA, which is a zip code tabulation area, is created by the US Census Bureau to approximate zip codes. They are stable over a 10-year period, and we currently use the 2010 ZICTA boundaries. Since ZICTAs are created by the largest provider of demographic data, the US Census Bureau, we are then able to get reliable population data for those ZICTAs. While the UDS Mapper is essential for the exploration of the reach of the health center program, there are some things to keep in mind when using the data. Although we use the most reliable and current data available, please remember that zip codes can change at the US Postal Service's discretion, but ZICTAs are updated less frequently. When the zip code layer is updated annually, every valid zip code and its data is mapped to the ZICTA that best fits that location. This means that any reported health center patients are never left out of the counts or analyses due to a new or changed zip code. Second, I also want you to remember that the patient data only come from one type of safety net program, the health center program, including awardees and lookalikes. Services provided by other safety net provider types are not yet represented in the UDS Mapper. Third, remember that the patient data are reported by zip code, therefore currently they can only be analyzed and displayed at the ZICTA level, so not by county, not by census tract, not any other geography. Fourth, when a health center doesn't report 11 or more patients in a given ZICTA, those patients are not included in the analysis of that ZICTA. This is done to leave out service area outliers and protect patient confidentiality. Also, please note that the UDS data do not provide direct information on patient income at the zip code level. So low income penetration calculations in the UDS Mapper are based on the assumption that 100% of health center program patients are low income. Nationally, in 2018, 91.3% of all health center patients of known income were low income. So we're comfortable with this assumption. However, please remember that this is only an estimate, and it can be used as a starting point for assessing the role of health centers in the service area, but should not always be the final answer. That's especially true in a rural state like Wyoming, where the problem of access is not necessarily a financial barrier, but maybe having any provider at all in town. So people of all income levels are using that provider. In that case, looking at different layers, such as penetration of the total population, may be more appropriate. The more considerations, the data from the UDS are only available for a calendar year. We can't see data for past years or any time periods beyond a calendar year. Patient data are only available at the organization level. We can't view data for individual health center service delivery sites. And finally, as mentioned earlier, some of the population indicators are imputed. If you're interested in reading about that full methodology used in creating the estimates, they can be found on the UDS Mapper tutorials and resources page under data estimation methodologies, and Jessica will be showing that, just where that page is later. So going into how we would define our community, there are several ways to define your community using the UDS Mapper. Sometimes a larger area, such as a state or county, may be appropriate. Service areas may be very relevant geography to use, but there are different ways to think about a service area. So for example, I can think of the health center program as a whole, and where does the federal program serve people in the community? So that's looking at all the health centers collectively in an area and what areas are being well served overall and what areas may not be as well served. Second, we could think about service area based on where our patients came from over a certain period of time. Currently, you can view these based on your 2018 UDS report in the UDS Mapper. Third, we can think about the area that you're actually funded to serve. Organizations frequently get funding from multiple funders, so you may have many different funded service areas to consider. Please note that the UDS Mapper does not include a function that shows you the area that your organization is funded to serve by the health center program, but you should have that information at your health center and be able to select that area using the tools in the UDS Mapper. Whatever you decide as your community to start with, I recommend starting large and then narrowing your area throughout the community health needs assessment process, which we'll demonstrate in a few minutes. The goal of today's webinar is not to make you professional cartographers, but you should understand that the techniques we use to display the data in the UDS Mapper, one visualization technique we use is called thematic mapping. Some of you may have heard the term choropleth mapping, and that's when you color in areas based on a number in a data set. So those areas will then be different colors on the map, allowing you to quickly compare areas based on those data. We also use something called threshold mapping, and with that visualization method, all areas will be the same color if their data value is within range of the values that a user sets in the tool. So for example, I will set a threshold. I only want to see areas that are equal to or greater than a certain number. And then areas that are not within that threshold will not be colored in. areas that are within that threshold will be colored in. And you'll see this later in the webinar. So now that you know about the UDS Mapper a little bit, at least, we thought we'd share some of the types of projects that might require a benefit from a community health needs assessment. These types of projects include strategic planning, grant writing, research, clinical planning, and population health related projects. Health centers have embraced the UDS Mapper to inform these types of projects. And today's hypothetical use case will illustrate how the UDS Mapper can be used to perform a CHNI to inform strategic planning. So I'm going to advance the slide, but I'm going to also launch my next poll question, pop quiz. What types of projects can the UDS Mapper be used for? You can select multiple. I'll give you a little bit to answer that. So what we see here is that, yes, the UDS Mapper can actually be used for all of these types of projects. Again, strategic planning being the one most often used, next to grant writing. We know that several people are using it for research products, including any learners that you may have at your health centers, including interns or residents or anyone that has any sort of scholarly activity that they need to complete. The UDS Mapper is a great free tool to help them do that. But it can also be used in terms of clinical planning. What are the disease burdens in a community, and where should I place these services, et cetera. So you'll see that in the example that we're about to see. So with that, we'll talk about the case study a little bit. The CEO of Community Health Center of Central Wyoming, located in Casper, has the opportunity to expand. She'd like to use the UDS Mapper as part of a community health needs assessment, and she will present her work to the board as part of an overall strategic plan. Please note that while this is a real health center, the scenario is completely hypothetical, and keep that in mind as we will be uploading sample data set that is also completely fictitious. With that, I'm going to hand it over to Jessica.
Okay. Yes, I want to share screen one. Okay, so hopefully you can see my screen and hear me.
Yes, yes,
Okay.
you can.
Thanks, Jennifer. So I've already logged into the UDS Mapper and I've clicked go straight to the UDS Mapper on the welcome screen. So in a sense, I've closed the welcome screen and this is what we're seeing. And on the right, we're looking at the Explore Service Area tool here. So this is the default tool that's shown after you close the welcome screen. And here we can select ZICTAs to include in our community health needs assessment. And we can do this using these three modes here. So we have by geography, by patient origin, and by distance. And to start our analysis, we will be using by patient origin. But first, I will zoom in just to get closer to Casper, Wyoming. Here we go. And I'm also going to change my base map. So that is the layer that's just underneath the mapping work that we're going to do. So I'm going to click this button here in the lower left corner, and I'm going to select Canvas as my base map. It contains the fewest details, and it will just make it easier to see the analysis work that we're doing. So as we mentioned earlier, there are several ways to define your community. These include your funded service area, your patient origin service area, your county, or any other meaningful geographies. And we also mentioned that researchers recommend starting with a community that's large enough to demonstrate measurable results. So to start this process, we'll go ahead and look at our core patient origin service area. So before I do this, I'm going to launch the last poll question that pertains to this core patient origin service area. So true or false, a core service area includes 90% of your patients. And this is a little pop quiz. No, it's just, we'll reveal the answer just here in a second. Just true or false. Okay, so the answer is actually false. And we will see here that that is because it defaults to the core service area of 75%. The mapper defaults to this, which we'll see here in a second. So I've selected this by patient origin mode in the Explore Service Area tool. And you can see that these health center administrative locations turn on and they cannot be turned off in this mode. So when I click the health center I'm interested in, which in this case is the Community Health Center of Central Wyoming, I'll see some, here we go, diagonal lines. And these represent that core service area, which is 75%, seen over here, of where patients are coming from. So I'm going to zoom in a bit. And this map actually may look familiar to you. The map and other data for each health center are found on the Bureau of Primary Healthcare website. So I'll just show you this website here. The data and the information card deck that Jennifer mentioned can be found here as well, down here. But for those of you who've seen this page before, you may be familiar with the service area maps that are on these pages. So I've already pulled up the Community Health Center of Central Wyoming. I'm going to open the service area map here. And this map shows all of the areas that the Community Health Center of Central Wyoming served in 2018. So the darker blue colors are part of the core service area for this organization. And the core area is what we just showed in the mapper. So I have said core a few times and I have mentioned 75%, but I'm going to switch back to the slides to explain this a little bit better here. So make this a little bigger. Your core service area helps you see the areas where most of your patients live. So this concept comes from something called the Griffith Commitment Index, which I have a hard time saying. It was published in 1972, looking at businesses and what areas customers come from. So the core service area tells us where most of our business comes from. The Griffith Commitment Index states that you should include between 70 and 80% of a customer base in a core service area. And the Bureau of Primary Healthcare has chosen 75% as the marker to indicate core service area. So let's see that we've pulled patient data out of our EHR and are looking at the data by zip code. And I want to rank order these zip codes from the most patients to the fewest. And I'm then going to build a service area with these data. So I'll start with the zip code with the most patients and add that to my service area. And then I'm going to keep going down the list, adding zip codes until the cumulative percentage I have included is 75%, which you can see stops at that first arrow in the middle column. And that's what the core service area will show. Each zip code added will have fewer and fewer patients. In this example, the next 12 zip codes actually have fewer total patients than the first 3. And on the Bureau of Primary Healthcare website service area map, the light blue areas that we saw show up to 100% of patients. And this only includes ZICDAs where the health center saw at least 11 patients. So I'll just go ahead and go back to the mapper then. And we can adjust the service area to show more or fewer ZICDAs. If we want to see that 100% service area, you'll drag this slider here on the right all the way to the right. Okay, so now it says 100. And because we want to start with a larger community, then narrow it down, we can start with this larger group of ZICDAs. I'm going to click Go to Selected Area down here because this will zoom me out so I can see all of the ZICDAs that I just selected. So next we'll use some other tools in the mapper to narrow down this very large group. So because you currently cannot deselect ZICDAs once you've set your by patient origin mode slider, we'll do some work in the data table and then switch to by geography mode. So I'm going to open the data table by clicking this icon in the lower left toolkit. Looks like a little window. And then here I see all the ZICDAs where at least 11 patients live and went to the Community Health Center of Central Wyoming in 2018. So the same ZICDAs that we saw on the map. By default, items under this standard UDS Mapper report tab are going to be included in this data table. And if you'd like to add additional data, you can do so by using these tabs here. Because I know I might need it later, I'm going to click the additional health center related data tab and then select 2-year change in patients. Okay. So, and then so that I can add these ZICDAs to the mapper in by geography mode and look at that data point later, I'm going to download this as a CSV file. So first I'm going to check to make sure that everything I want is included here. And then I'll click this arrow in the upper right corner of the data table. And I'm going to save the file on my computer when it pops up. Okay, so after I've downloaded my file and I see it over here in the lower left, I'm going to go ahead and just close the data table by clicking this X. And now I'm going to change my Explore Surface Area mode to by geography. Right, I'm going to open my spreadsheet, just double click on this. And because we want to reselect our patient origin ZICDAs here, hopefully this will open here in a second. Here we go. I'm going to copy these ZICDAs on the spreadsheet. I'll just do a Control-C, go back to the map, and then I'm going to open this clipboard tool here, which will allow me to paste the ZICDAs into this box. So I'm just going to click into the box and do a Control-V on my keyboard. I'm going to click Validate. And I get a message here telling me that all of my zip codes were ZICDAs. So I click OK, and then I click Add. So again, if you want to be sure your map is zoomed and centered on the ZICDAs you've selected, you can click this Go to Selected Area button here. So now we're seeing the same ZICDAs we had selected in by patient origin mode, but we have a selected ZICDAs box here we can use to deselect if you'd like. So to make this a little easier, I'm going to turn on my ZICDA labels. Okay, so here in the Boundaries and Optional Layers tool, you can add or remove various boundaries, and we'll see this again later. But I can also turn on their labels by clicking this button here on the right. I have to be at a certain zoom level, so I'm going to zoom in one more time. Now it lets me turn on those labels. And as I zoom in and out, the labels will turn off and on depending on where I am. But they will be there when we need them later. So now I'm going to zoom back out one time and open the Main Maps tool by clicking this little icon here. So this is so that we can look at some thematic maps that show different categories of data using colors. So I'm going to click on Population Data. So by choosing Population Data and then opening these lists of maps, you can look at the percent of population by ZICDA that fit into these categories. So you can look at income, race, ethnicity, age, and employment, different things like this. So I'm going to just click low income. So in these demographic layers, the darker the color, the higher the percentage of people with the characteristic we've chosen. So I'm going to open the legend by clicking the legend button here in the lower left toolkit. These layers here start off at 100% visibility or opacity so that users can clearly see the data. But if you'd like to make them more or less visible, you can use this slider here. And as you move the slider, the legend adjusts as well automatically. So I will go ahead and make it 100% again. Turn off my main map by clicking No Main Map Selected so that we can look at some UDS data on penetration. So I want to look at this penetration data to help me choose areas with low penetration of the low-income population. And low-income penetration refers to the percentage of the low-income population in a ZICDA that go to any health center organization. And by low income, we mean people living below 200% of the federal poverty level. So for example, if there are 50 people of low income living in a ZICDA and 25 of them visited any health center organization in 2018, that low income penetration rate would be 50%. Okay, so I've selected UDS data. I'm going to select penetration of low income here. My legend is open. So I can see in the legend that the ZICTAs that are this lightest green color have less than 20% penetration of low income. So for the purposes of this presentation, we want to look for ZICTAs with low income penetration rates less than 20%. Okay, so these, the ones that are colored like this. So if I'm not sure which color represents which values, which can be tricky, especially when you have selected ZICTAs because they're shaded, I can navigate to the toolkit here in the lower left corner. I'm going to activate what we call the information card by clicking the I button here. And so now as I mouse over a ZICTA or click on it, I can see its penetration rates. So for 82501, I see the penetration is 30.45%. For 82520, I see it is 2.59%, etc. So now that we know what our colors represent, we can go back into the Explore Service Area tool and deselect some ZICTAs with low income penetration rates of 20% or higher. So you can hover over a ZICTA's name in the selected ZICTA's box to activate a red X, and then you can use that to deselect that ZICTA like I just did. You can also just click on any ZICTA in the map, which I'll do for the rest of these that are not the lightest green color. So I'm deselecting the ZICTAs that have more than 20% penetration. Okay, so I should end up with 14. I have too many here. Okay, so this one needs to go up, and then this one, and this one. So let's see. Okay, there's 14. All right, so these 14 ZICTAs that we're left with have relatively low rates of health center penetration of the low income population. So now we'd like to continue with narrowing down our target area by finding ZICTAs that have not seen gains in numbers of patients. So I'm going to go back to my main maps, and this time I'll open the list of percent change maps and select 2-year change in patients. So in the legend, which I'll open again, we can easily see the ZICTAs with 50 to 100% loss and 10 to 50% loss, right? They're orange and red. And we can also see the ones with 10 to 50% gain, 50% or more gain, or newly served, because those are all dark blue or light blue. But because we want to deselect all ZICTAs without gains in patients, I'm just going to start by deselecting these orange ZICTAs. So I'm going to go back to the Explore Service Area tool and just click on these orange ZICTAs. So they're not, okay, seeing gains. And then I don't see any red ZICTAs, but we do want to exclude all ZICTAs with no gain. Okay, so we see that there's a category here that's less than 10% change, and that includes gains or losses. Okay, so because of this, we need to look at the data we downloaded from our data table to see if there are any that we can deselect here. So when I look at this list, I see that 82443 has a 0% change in patients. So it did not see any gains. Okay, so that means we do want to deselect this ZICTA. So I'm going to go remember that 82443, go back into the map and just deselect it here. Okay, so that should leave us with 11. So to recap what we've done so far, we did start with every ZICTA with more than 11 patients who went to the Community Health Center of Central Wyoming. And then we narrowed down our target area by deselecting ZICTAs with higher penetration rates. So meaning the ZICTAs remaining in our target area have room for growth. And then we further narrowed our target area by deselecting ZICTAs with no gain in patients or growth over the past 2 years. And so now we're left with these 11 ZICTAs from our overall patient service area that are growing and have room for growth. So I'm going to turn off this main map, and we can now further target our area by looking at various indicators of need. So this can include data on chronic conditions or any other health data. And we'll also look at what health facilities, such as rural health clinics or hospitals, are located within or near our target area. If we aren't seeing any, this could indicate further need as well. So I'm going to open the population indicators tool first. Looks like these 3 people. And earlier you saw thematic maps using the main maps tool. So this population indicators tool shows us threshold maps. So the threshold maps will highlight any ZICTAs that fall within a range or threshold that you set. So by simply checking a box here, let me scroll down a little bit, you'll see the ZICTAs that have values greater than the national average, okay? So I just checked adults with no dental visit, and the ZICTAs that became colored have rates of adults with no dental visit that are higher than the national average, which is 34% here. So other benchmarks you might be interested in are clinical benchmarks, other published benchmarks such as Healthy People Goals, or your state averages. Because in our case study, we want to use a benchmark that's more appropriate for our service area. Let's go ahead and look at some state benchmarks, which happen to be in the UDS Mapper. So I'm going to open the tutorials and resources page here. I'm just going to open it in a new tab just in case. And scroll down to the benchmarks for population indicators section. Okay, so here I'm going to scroll down to the table that has no dental visit, and that's the second table. So percent no dental visit for Wyoming is 33.3. Okay, that's the state average. So I'll go back to the map and I can set this, it's 34 now. Okay, I'll set it to 33. So it's not much of a difference, but we did see some areas become filled when we made that change. Okay, so in the population indicators tool, again, just like in by patient origin, you can adjust any of these sliders to your relevant benchmarks. So you can also turn on more than one indicator at a time. So let me turn off dental visits for now. And let's look at adults who delayed or did not seek care due to cost. Earlier, I looked up the state rate in that same benchmarks table, and it was 15. So I'm going to change my slider to 15. And now the ZICTAs that are bluish green have rates of adults who delayed or did not seek care due to cost that are higher than the state benchmark. So let's add another indicator, adults with no usual source of care. The state rate here that I looked up earlier is 32. So I'll move my slider to 32. And I'm going to also turn dental visits back on. That's still set at 33, which is also the state rate. So now we see the tan ZICTAs have higher than state averages for no dental visits. The bluish green ZICTAs have higher than state averages for delayed care due to cost or not seeking care due to cost. And the purple ZICTAs have higher than state rates of no usual source of care. So we also see some blended areas that have more than one rate above the state average. If you need to see these more clearly, it does get a little difficult. You can turn them off and on just to see which ones are overlapping, for example, if you're interested. So to summarize where we are, we started with the core patient origin service area for Community Health Center of Central Wyoming, widened it to include the entire service area, and then narrowed down our target area. So we did this by selecting ZICTAs with low penetration rates that have seen some growth over the past 2 years. And this shows us where the health center program or my health center specifically may have room to grow. So then we further narrowed down our target based on potential need, looking at ZICTAs with higher than state average of no dental visit, delayed or did not seek care, and no usual source of care. So only 4 of our remaining ZICTAs have high rates or rates higher than those state benchmarks that we set. But we see there's one, 82301 in Rollins, that was higher for all 4. Okay, so as we mentioned earlier, all of these data are available for download in the data table. I'll just show you that one more time. Because we just showed, earlier I showed health center program data that was under this tab. But if you're interested in downloading those population data that we just saw, or health indicators or other indicators of need, they're under this additional population data and indicators tab. So you add items you're interested in. So if I wanted no dental visit, delayed, did not seek care, I would go ahead and select everything I want. I can download the data set like I showed you earlier. And you can also print the data set by clicking the printer icon. And you can print as a PDF or as a regular printout. So I just want to return the slides for 1 second. Just a couple of considerations for rural areas we wanted to mention. So as Jennifer said, ZICTAs are a compromise. So one reason for this is because in rural areas, ZICTAs may seem very large. The town or population you serve may actually be smaller than one ZICTA. So Rawlins comprises most of 82301, according to my research, but not all of it. And it shares that ZICTA with Reiner, Muddy Gap, and Three Forks. And then according to the UDS Mapper, this ZICTA, the entire ZICTA has a population of 9,176. But a quick Google search shows that Rawlins has a population of around 8,500. So while the town is a portion of the ZICTA, in this case, the bulk of the population probably lives in that town. But this is up to you. If you know more or you want to use your local knowledge, then you can put that into the narrative portion of your application or submission if you're doing a grant application for HRSA to explain that the town you serve is smaller because we are, as we say, stuck with the ZICTA level data. One more consideration is that ZICTAs may misrepresent need, excuse me. So in ZICTA 82301, we can see that a large number of low-income people are not served by health centers, especially when compared with surrounding ZICTAs. But we don't know if those with unmet need are in Rawlins or in another area within the ZICTA. So this is just another instance of where you need to use your local knowledge alongside the data from the UDS Mapper. All right, so let's see, I'm almost out of time here. I'll talk fast. So what other providers are in the area? We've identified this ZICTA here as having potential need. So that means it has an increasing number of patients, low penetration rates. But these conclusions were based on UDS data only. So we don't have data about other providers, such as rural health clinics, because they don't report into the UDS. So we should also look just to see if there are other providers in the area by adding them to the map. So I'm going to open the Explore Health-Related Facilities tool by clicking this icon here. And if you're interested in a type of facility that's not included in this list in the UDS Mapper, you can map your own point data as long as it's not patient data by using this Map My Data tool. We don't have time to show that today, but it is available in support materials, or you can contact us if you have questions. But here in this list, I want to see, let's see, I'm going to add rural health clinics, hospitals, and tribal organizations. So as you can see in the legend, tribal organizations are included in the facility and point HPSA layer. So that's why I added that. All right, so we see there are a few sites surrounding our ZICTA of interest, but nothing real close. So determine how close your site is to existing services. You can add other layers. So I'm going to open again this Boundaries and Optional Layers tool. This is where I turned on the ZICTA labels earlier. I'm going to add highways. Okay, so we can take a closer look at drive times. Now I'm going to go back to the Explore Service area, and I'm going to change to by distance mode. Clicking this button here. So this allows me to see a distance or drive time from any potential address or site. So I'm going to click this blue point here and then click again on the map right above this intersection. And so by default, the mapper will show me the ZICTAs within a 30-minute drive time. And I can see that this site is not within a 30-minute drive time of any other health facilities beyond the hospital here. So to summarize, using the by patient origin mode, we identified 100% of ZICTAs that comprise the health center service area. We then used thematic maps to eliminate ZICTAs with more than 20% penetration of the low-income population and no gain in patients over the past 2 years. We also used population indicators to create threshold maps and identified remaining ZICTAs that have potential need, defined as high rates of adults with no dental visit, no usual source of care, or adults who delayed or did not seek care due to cost. Then we chose this one ZICTA in Rollins as our focus. We added hospitals, rural health clinics, and facility and point HIPSAs to see if there are other safety net providers in the area. And then using the by distance mode of the Explorer Service Area tool, we selected ZICTAs within a 30-minute drive time of our potential sites to check for overlap, which we did not find. And then another reason we added the hospitals and the other health-related facilities was to look for potential partners, which we did find here in this hospital. So now that we've gone through an example of how to use the UDS Mapper as part of a community health needs assessment, I want to show you the support resources available within the tool. So I'm going to go back to the home page here and click tutorials and resources. And this is where I found the benchmarks table earlier. Here you can also find under webinars and presentations, where you can sign up for our future UDS Mapper webinars. You can also find tutorials, a knowledge base, data estimation methodologies, and many other resources. You can, if you have questions or additional feedback, you can use this Contact Us button. You can also contact the Bureau of Primary Health Care or sign up for HRSA's Primary Healthcare Digest at bipic.hrsa.gov. And then finally, you can click this bubble, which is usually in the upper right of the screen. If we're not helping others or giving a webinar, the bubble will say chat. But if it says help, you can still click it and just leave us a message. It will show you a form that you can use to leave a message. And finally, you can connect with HRSA at hrsa.gov or follow them on Facebook, Twitter, LinkedIn, and YouTube. And that concludes the demonstration portion.
Wow.
Jessica, can you just show where to find the upcoming webinars on the website?
Sure. So if you go under tutorials and resources, and then webinars and presentations, here we have all of our upcoming webinars listed, including introductory webinars, which are monthly, advanced topic webinars, which vary by topic, but they're also monthly, and then occasional special topic webinars. They're free, they're open to the public. We encourage you to attend, and you just need to click one of these registration links to go ahead and register.
Perfect, thank you. I think that was the only question I saw in the chat. Are there any other questions? We've got a couple minutes.
I just had a question. Since the webinars are open to the public, do you guys get a feel for who else beyond the HRSA and Health Center world click in, or do you keep track of that?
We get not just from the webinars, but from the user registration. We can tell when a new semester is starting because there are definitely some professors who are using it in their class. We get a bunch of students registering at one time. We have seen it being used, like I said, at medical schools and residency programs for scholarly activities that are required to do population health type exercises. So it's just a really wide variety. And we have some kooky things like HVAC repairmen who are using it to help their routing of their day. So a wide variety of people have found it for various reasons, but the majority are people who are in the health center world, either health centers, PCAs, HRSA, or other supporting organizations.
Wow. Well, this is phenomenal information. I'm always blown away every time I see it. So thank you guys so much.
You're welcome. Happy to do it. Like I said, 10 years down, and hopefully at least 10 more years in the future, right?
I don't know how we do without it now. I mean, it's become an integral part of our work, I think.
Well, that's excellent to hear.
Yeah, thank you so much. This was incredible. It was, as I was seeing you demonstrate the different functionalities, I could see all sorts of applications of this for work that I have done in the past that I wish I would have applied this incredible resource to. So I just wanted to, we're at the top of the hour, so we will be sending out an evaluation shortly, and there will be an opportunity to submit a request for one-on-one TA from Health Landscape within it if you would be interested in learning how to apply UDS Mapper to your health center planning. So thank you so much for joining. Have a great day, everyone.
Thanks, everybody.
Thank
Thanks
you.
for having us.
Thank you.